and restart. Thanks, Sydney. And then if while you're typing in the chat, you want to share any wins from your team this month, any good things that are happening on your unit or with your C-section rates, maybe any new changes that you've tried since we spoke last month. We would love to celebrate wins with you. Yay, Amy's sharing a win. She says Q1 data was impressively improved, and not just improved, but impressively improved. That's worth celebrating. Hey, Jesse, you're still welcome, even if you're new to the group. Ooh, Emily shared charge nurse C-section rates. Wow, very exciting. If you guys have questions for Emily at Denver Health about how they did it, feel free to reach out to her. That's a change idea that a lot of our hospitals have been contemplating this year. Sharing not just provider rates, but nurse rates, and what's the best way to go about that. All right, we can go ahead and go to the next slide, Sydney. Again, this is just our team members that you're going to see here on this next slide. Today, you're going to hear from me. And Gretchen is going to present some on our data. If you don't know Gretchen already, she is our fantastic data analyst. She handles all things data and REDCap for us, and she's going to walk through some of her world with us today. And we can go to the next slide. You guys are already sharing wins. Keep putting them in. We want to celebrate with you. I know you guys are doing great things. We've had a lot of one-on-ones lately with our hospital teams, and every time we speak to you guys, we uncover all of these amazing things that you're doing, but we didn't know about. And so please share with your peers here what you're doing and how it's working. I'll share a win. Z just signed on. Z spoke at a doula panel for us this month. There was a statewide midwifery symposium, and we had a doula panel on different doula integration programs and how different hospitals are integrating doula. Have used the checklist, you know that that's a huge step. I'll celebrate for Laurel. Laurel, you guys submitted data for the first time. That is also a huge win, so celebrate with your team for that. All right, before we get going, I have a poll. Sydney, if you have our poll ready, let's do it. Because we're going to focus on all things data today, I want to get something real straight here. How do you pronounce data? Is it data? Is it data? Do you think it doesn't matter? They're both correct. Or does it depend on how fancy you're feeling for the day? Let us know so we can get it right today.
Based on the results of this, I'm going to have to change my pronunciation for the rest of my presentation.
Well, I often rotate, or I just adopt the pronunciation whoever I'm talking with is using. A lot of people are saying it's both correct. I do. I actually looked it up before the meeting, and it is actually both correct. Kate shared with us that their C-section rate this month is less than 8%. Huge win. Excellent work. All right, that's enough. We can close the poll. I think they're both correct, but if you say data, I'll say data. We'll both be correct. We'll share those results. And there we are. All right, guys, thanks for humoring us. All right, we can go to the next slide. This is what we're going to do today. We're going to hear from one of our hospital teams. Good Sam has signed up to share out what's going on in their facility today, and then we're going to jump into all things data, talk about how some of our hospitals are using their data out in the field. Gretchen is going to do an in-depth dive into our dashboards. We're going to talk about state-based data that we present back to you guys from the Department of Public Health, and then I'm going to give you guys a little insight into the labor culture survey results that we did earlier. We are going to have a breakout, so if you have a camera and can turn it on at least for the breakout session. We would love that. And then we'll end up with covering a couple of our structure measures for our program. So we can go ahead and go to the next slide. And I will introduce Amy Dempsey. Amy, are you here? We're happy to let you screen share if you have slides you want to use.
Actually, they did not give me any slides, so I can just talk if that works for you guys.
That works perfect for us, Amy. You're on stage.
Okay, great. Well, Good Samaritan started with a greater than 40% cesarean birth rate for NTSV patients when we started this project. And they really have just nailed it. The work that they've done has been phenomenal. And they are at as low as 15% 1 month. And first quarter was 23%. So that means it wasn't just a fluke, but that we have reached, or at least have started to gain some momentum and are working on sustainability. This month I noticed it popped up again. So we just need to stay the course and keep making sure that we have our eye on the ball and continue to focus on it. But I'm really proud of that first quarter rate of 23%. So also notable is that we have 2 main practices at Good Samaritan, and one was definitely, our larger group was raising our rates. Our smaller group was pretty consistent. And this past month, they switched places. So the larger group had the lower rate, which we're just thrilled about. We've also been working with Epic to try to create a report. It's not as easy to pull our nursing rates, but we decided that we wanted to try to also, rather than just giving providers their NTSV cesarean birth rates, we also wanted to give that to nurses. So we've been working on pulling a report. We're trying to validate that data right now, but the initial reports that we gave, we handed out to the nurses, and that went well. And then we've also had an action group that includes the senior leaders, the practice leads, and nursing leads to implement the plan and keep people accountable. So Good Sam's been doing really good at submitting and sharing data to help drive their results. They communicated shift huddles twice a day to keep it up front, and they also post their rates on a bulletin board right next to their patient data board, so that it's always visible and keeps it in the forefront. They have monthly meetings with their practice leads to go over data, and then the medical director reviews all the charts that fall out to look at legitimacy for decision making. So that's been nice for accountability. And then they also have buy-in from their nurses who actually collect the data and are helping with submission of data. So they have a lot of buy-in from their staff as well. They also were part of a system initiative that created manuals that are by stage of labor. So they give pictures and ideas for positions based on what stage the patient is in. So if they're in early labor, then they have a whole set of positions that they could consider. The expectation is that for every patient admitted for an induction, that they do the 3 balances from spinning babies. And then once they're in active labor, then they have another chapter in the manual that gives them another set of positions. Some of them are obviously repeated. When you make it to second stage, then they actually divided the manual into station. So depending on what station that you're assessing the patient to be, it gives you positions suggested based on station. And then we laminated these and put them into every room. So I love that it was a system initiatives. So every hospital in our system has these in every labor room. But I love that there were bedside nurses that were involved in creating the manual. And one of the key players was from Good Samaritan. So she's had a lot of ownership in this. And she actually did a skills fair station and owned that station and rolled this out when we went live in January. So that was really, really exciting. And then we also have deck docs that are serve in the hospitalist role at Good Sam, and they've agreed to be a part of the huddle if there's any questions or concerns prior to moving to a C-section. So that's been nice to have a provider colleague. And yeah, that's really, I think, the highlights of what we've done. I think the engagement, the data sharing, the manual has been huge, the nurse buy-in, and now physicians really having a role in this and has been really critical to our success. And then I think it also has helped that we've been held accountable to our rates at a system level. And so our leaders are really bought into making sure there's accountability, understanding that we have to report out at the system level if our rates are not meeting the metrics that we've set as a system, which is 23.6.
Amy, amazing news. I'm so proud of Good Sam, right? I mean, you were really transparent with us that you guys started at a pretty high rate and you really doubled down on your efforts this year, right? And so it's really fun to finally see the needle moving for your team who's put in so much work. I'm not surprised that people in the chat are demanding to see your resources. If you are willing to share it, we would love to share it. You could share it either individually or you could always send it to Sydney and she could share it out if that's something that you guys would be willing to make public. And then there's just a couple of questions in the chat. If you want to take a second and can stay on to answer those. Guys, if you have questions for Amy,
The
please put
rates
them
we
in the
did
chat.
unblinded, but we only did the top 10 performers. We didn't do the lower end of the spectrum. So I can't remember actually the top number of performers that we did, but it wasn't a complete spectrum. So that's how we worked around that negativity around unblinding.
Mm-hmm. Yeah, great. And then I think their nurse peers know who to look to then, right? I mean, they know sort of who are the top people who really know how to do all of the tips and tricks in labor. I think that's a really smart way to go about it.
Yes. I'm a little hesitant to share the manual with everyone because there's a lot of copyrighted materials in there that we didn't yeah, I'll just leave it at that. So it's very, very heavy on spinning babies, but even more so bundle birth. There's a lot taken from bundle birth, and then there's a lot just from the internet that the nurses gathered and put into it. So for that reason, if you want to put emails in here, I can do it individually, but would rather not put it in the official website.
That sounds awesome, Amy. Yeah, and I think for everyone who's going to receive it, like just be mindful, right? Like heed Amy's warning.
Right. And no judgment, please.
And I don't want to sort of spill the news too early, but we are planning to host labor support workshops this year. We'll give you guys some more information. And we do expect to come out of those workshops with some sort of hard copy materials similar to Amy's bundle. So there'll be a couple opportunities this year for you guys to get similar materials. All right, Amy, thank you. Always a pleasure. All right, guys, before we move into talking all things data, I think it's really important just to ground us in what our team goals are this year. So for the entire cohort, all of our hospitals who are participating, we've sort of set 3 really overarching goals. I know you all have your individual goals within your hospitals, but all of our data decisions are sort of driven by these 3 goals, which is 1, to be proactive in how we're addressing Colorado's NTSB C-section rate, which has been slowly creeping up since 2016. We also want to narrow the variation that we're seeing between providers, hospitals, regions. And then finally, we want to move towards examining the disparities. We know that they exist nationally and in Colorado, and we're improving our data collection and analysis to help you guys identify those on a hospital level. We can go ahead and go to the next slide. Perfect. For those of you who were or were not with us last month, it is a recorded session. You can find it on our YouTube. Sydney will probably link it in our follow-up email. We got to hear from Denver Health. They shared their intermittent auscultation policy. Many of you guys were interested in hearing about that and seeing that. Again, it's recorded. They also shared out their policy with us. And then we talked about strategies to manage resistance to change. We know that with any change, especially quality improvement change ideas within a system, you will get resistance. And so we talked about some of the ways that you guys could approach that head on. The structure measure that we covered last month was talking about if you guys use labor huddles to communicate labor progress with the patient. And that looks a little bit different at every hospital, is the feedback that we've gotten. And we plan to develop some tools to offer you guys some guidance if you want to standardize what you're doing with that. We can go ahead and go to the next slide. Just like Amy shared out for Good Sam and other hospitals have done previously, we want you guys to sign up to share out with us. Hospitals love to hear what you're doing. I mean, if you guys enjoyed hearing Amy just now, let's give back to the group, right? Sign up for us. Let us know what you guys are doing. It can be as informal as we just did. You don't have to have slides. You can use slides if you want. You can share your data. You can just share the ideas that you're using. We really would just really like for you guys to share what's going on. And so Sydney will share this link after in the follow-up email as well. Please don't be shy. If no one shares up for a specific month, we will recruit. So if you have a month that you prefer to share out, go ahead and sign up. We really need to hear from you. This is a learning collaborative, and the way that we collaborative learn is to share with each other what we're doing. All right, go ahead and go to the next slide. Perfect. All right, so I wanted to start with why are we talking about data? It's not always the sexiest topic. We have 20 people on the line today because you were interested in learning more about this. And I think, I came across this quote when I did my quality improvement training, and it was really kind of hard hitting for me. And that is, what gets measured gets managed, even when it's pointless to measure it and manage it, and even if it harms the purpose of the organization to do so. And I think I really kind of like to keep this at the forefront when I'm making data decisions within a quality improvement program, because we want to be mindful of what we're looking at. One, we don't want to waste your time collecting data that we're not using for quality improvement. And two, we want to collect the data that's most useful to your quality improvement. And so we know that the closer you examine outcomes, sort of the more attention that they get, and we want to be focusing on the outcomes that are most meaningful for you and for your patients and for the providers at your hospital. And so I wanted to reassure you that sometimes data can feel big in quality improvement, and it definitely takes an extra step of effort to do data well. But know that our team has really tried hard to put some thought behind the data that we ask of you in order to use it in a really meaningful way. So we can go ahead and go to the next slide. Thank you. All right, I'm going to share two hospitals, a little bit of detail about how they're using data. One of our larger volume hospitals has begun taking their data to the next step and submitting some data that they don't have to submit, right? So they've elected to submit additional data for us. And the reason that they did this is because they really want to nail down on, let me start with saying, they were noticing that there were disparities in their NTSVC sections by race and ethnicity, right? We did some statistical analysis on their rates over a longer period of time, and there were statistically significant disparities in their rates at their hospital. And so they said, what do we need to do for those, right? That next step is then, let's go ahead and look by indications for their C-sections, why the patients had the C-sections, then by race and ethnicity. Let's break it down one level further. Not did they have a C-section or not, but this is why did they actually have a C-section? What was the diagnosis that they had for their C-section? And then looking for disparities within those individual diagnoses in order to have targeted quality improvement. Guys, this is a step beyond what we're asking of you, but know that if you have a great idea for how you want to go that next step for quality improvement at your hospital, we are willing to work with you on it. Gretchen always has a smile on her face when we're talking about data. And so we wanted to share that like the basics are going to be covered today in our data dashboard, but this is one step further, and we're willing to go there with you guys if you want to. We can go ahead and go to the next slide. Northern Colorado Medical Center, they've shared a few times with us. You guys have seen their run charts over time, but I always go back to the fact that they really intelligently use data to get buy-in at their hospital. And so they, on their own, were looking at their run charts, were sharing their run charts, examining their rates, making sure all of the providers and nurses on their units were aware of the rates. at their own facility. And that's how they really got a lot of the providers, and particularly their family medicine residency program, on board with doing this program and using the labor dystocia clinical care checklist. Those residents got so excited about it that they helped integrate it into the EHR in order to make data collection and analysis easier for them. And they are publishing with us. They recently submitted a journal manuscript on their program and what they've done with SOAR. If you guys are interested in using your data to publish, that could be a poster presentation at a conference. That could be, again, a journal manuscript that you want to publish. We are happy to partner with you on that. Again, your data is very exciting. And for those of you who are making great strides in improving your rates, let's broadcast that, right? We want other hospitals and other states learning from what you guys are doing well. So we're super proud of the NCMC team and how they've been using their data. Go ahead and go to the next slide. And this is where I pass it over to Gretchen.
Hi, everyone. It's great to see so many familiar names and faces. For those that don't know me, my name is Gretchen Schultz. I'm the data analyst here at CPCQC. You've probably received at least a handful of emails from me, from Sydney, talking about data, requesting data from you all. And so I really wanted to talk through today how you can, one, access your data, and really how you can use it to share back with your team, with your hospital, again, doing further analyses. As Amber mentioned, if there's something that you really want to look into that we don't already capture, let's sit down and do that. I'm such a nerd, and as Amber mentioned, most people don't think data is super sexy. I happen to think it's incredibly sexy, and can really be such a powerful tool to give back to hospitals and to give back to your teams, to really show the incredible improvements that you all are making and the strides that you're doing for the SOAR program. So for those of you who don't know, you're more than welcome to access your data dashboard at any point in time. For those that don't have a login or need access, by all means, just send me an email. I'll go ahead and put my email in the chat. But for those of you who don't have access, send me an email. I'm more than happy to add you to that. And then we'll go ahead and get you access. So you'll go to cpcqc.org and click the hospital login tab at the top. And then you can go ahead and start navigating your dashboard. Obviously, those hospitals that are only participating in one of the programs, you'll only see one dashboard. This is just a screenshot of my access because I get to see all the various different dashboards. And with that, I'm going to go ahead and ask Sydney if I can go ahead and share my screen.
Always, Gretchen. You can always share your screen.
Always. Perfect. So hopefully everyone is able to see the login page now. And it will have a direct link to REDCap, so you can access REDCap through here and submit your data really easily. Here we have the SOAR cohort dashboard, which I'll show you just some of the features here. You have all of your various tabs across the top. Here we have our home page. You have these wonderful filters at the top of each of these pages that can help you sort of navigate the different quarters. So if I wanted to look at several quarters, including this one, I want to just make sure that I go ahead and select the same ones for both of those filters so that they're showing equally. Same thing with the wonderful NTSV rates. We now have a couple changes. We added a monthly, since we're doing monthly data collection, some more rapid feedback for you all to see sort of how your NTSV rates are going from month to month. So here you have the CPCQC cohort, you have the Colorado total, and then for you all, you'll have your own hospital in comparison to these as well. So we have this here by month, we have this here by quarter, and by year as well. And as you can see from this, the cohort has been really wonderful and has been really trying to stay around our goal of 23.6. You can see here that we decreased our cohort average NTSV rate from 21.1 in February to 21 flat in March. So congratulations to you all. Here we also have some demographics. Again, looking at, you'll have your hospital, and then you'll also have the cohort comparison. You'll also have payer type down here, broken out by cesarean and vaginal deliveries for all the different provider or the payer types. And again, we have these filters here, so you can, again, select all of them. You can select several. So this is a really fun way to really navigate through your data. Again, if there's things that are confusing or items that you want to show that aren't currently on the dashboard, we are more than welcome, more than happy to add those in. So always feel free to comment and ask for what data you guys need, because we do get some really wonderful data, both from you all submitting your labor dystocia checklists, but also from the state as a whole. I'm going to go ahead and stop sharing and go back. And Sydney, if you wouldn't mind coming back. Great. Thank you, thank you, thank you. So here we just have, again, what we saw in some of in the data dashboards. I'm going to just present some of the highlights, some of the really key important data elements that I like to look at, and I know that Amber likes to look at when we're doing sort of feedback and QI feedback for you all. These run charts here really are helpful for showing data over time. And again, we can see it from those month-to-month NTSV rates. We can see it by year. We can see it by quarter. And so it really helps to point out various changes over time increments, from really small time increments to really big time increments. And it can help point out different changes in procedures or events. I really like to sort of highlight what we all went through in 2020 and how that really changed not only our procedures, but a lot of our hospital NTSV rates. And so how can we use these run charts to sort of marker those different events and explain some of that as well? So I think run charts are a really helpful way to compare and show different implementations that you guys have done over the years and how that has affected your rate, or has affected your ability to submit labor dystocia checklists over time. Really powerful tool. Next slide, please. And we'll go into some of these labor dystocia criteria and how we've measured in terms of being met and not met. But here is just your wonderful labor dystocia criteria for failed induction of labor, arrest of dilation, and arrest of descent. Next slide, please. So here you'll see, and this is, again, screenshots from the data dashboards, you'll see on these MET criteria, your percentage of MET criteria. This is, for example, failed induction. You have the criteria, the 3 criteria for failed induction of labor. And then you have the number of NTSV cesarean deliveries, which were labeled as failed induction of labor. This comes directly from the data that you submit to us, those labor dystocia checklists. And then how many of those met criteria based on those 3 criteria listed at the top here. And then we can also see here on these bar charts, where are these patients not meeting the criteria and how can we go ahead and adjust for that? Where are they not meeting criteria, and what can we do to ensure that then we're making those improvements so that each patient that does go in to a cesarean based on a failed induction of labor does in fact meet all 3 criteria. Next slide, please. Here we have a very similar view of arrest of dilation. Again, we have our 3 different criteria up above, and then the percent in which we're meeting criteria based on the fact that we had 6 NTSV deliveries that were labeled as arrest of dilation, and then there were 5 that met criteria. And if you see down here in this first bar graph, the one that did not meet criteria really just fell under, did that patient reach 6 centimeters of dilation or greater? And 1 patient did not. And so that's how we're measuring sort of, did they meet the criteria, yes or no? And again, bringing that attention back to your team huddles or back to your unit and saying, this is where we fell short on this one instance. What can we do to make sure that we are identifying these patients correctly and that they are in fact meeting all 3 criteria that we're asking? Next slide, please. Lastly, this is your MET criteria for arrest of descent. We have just 1 criteria, and that is at least, did the patient push for at least 3 hours with inadequate fetal descent? That was a change from last year. And so we have here, again, this particular example had 100% in terms of MET criteria. They had 5 patients, or NTSV labor dystocia checklists that were listed as arrest of descent. All 5 did meet that criteria in terms of pushing. And it's a really wonderful way, again, to be able to see what was a presentation at delivery, was an option or an operative vaginal delivery offered. Did the patient take that? Yes or no? It's a really powerful tool to really see where you can be making improvements to make sure that on these 3 different labor dystocias, all of the patients are meeting that criteria. I want to just pause for a moment and ask you all to put in the chat, what data do you think is most useful for your hospital at this current time? It's always something of interest to me. It's something that really helps guide us in our ability to be able to reflect that information back to you in a really easy way that you guys can then take back to your units, back to your C-suites, and show the wonderful work you all are doing. While you all are putting that in the chat, let's talk race, ethnicity, and provider. So here I showed a little bit on that demographics tab. You have your race ethnicities. Here we have the pie charts broken out by vaginal and cesarean. This is data that we actually get from CDPHE, from the Colorado Department of Public Health. Oh, I think we got a blank screen. I can also share, Sydney. Bear with us one moment. Here we go. Cool. So I really think that this is a really powerful tool in order to be able to see the MTSVs both for vaginal and cesarean by race and pair, and compare to the CPCQC cohort. You'll notice that on your demographics tab, on your own personal dashboard, you'll see your hospital and then you'll see the cohort comparison. And that can be a really great way to be able to look between the two. Same thing for the hospital pair types. You'll be able to see these bar charts not only for your hospital, but how they compare to the cohort overall. And again, as Amber mentioned up above, in terms of looking at disparities, I know that's something that we're all looking into and have been for a while, and how can we start to identify and what can we do about some of these disparities. And so I think this is a really powerful tool to be able to look at, okay, who are our main patients? What are their race and ethnicity demographics? What are their pair demographics? Are we seeing that reflected in our data, in our NTSVs? Are we seeing that reflected in our who's meeting criteria for the various labor dystocias? Are we seeing this by indication for cesarean delivery? I think these can all be really incredible tools to be able to see and notice what's going on the back end that we might not be able to see sort of day by day, but on a much larger scale, can we see over the year or over the quarter, yes, this is actually following the trend of who our main patients are by race, ethnicity, and pair, or are we seeing that there's some slight skewing happening for NTSVs? Lastly, I just want to take you through sort of how we're using the data. These are just 4 of many ways that we're using the data. First and most importantly, I want to just mention that we get data not only from your labor dystocia checklist, but we do also get quite a bit of data from birth certificates that come to us from the Colorado Department of Public Health, which helps us be able to give you a much bigger breadth of all of the data that you guys have in your hospitals and how we can go ahead and utilize that for our program evaluation and quality improvement. And so with this program evaluation and changes, as many of you know, we switched up the SOAR program this year to really be able to show more timely quality improvements and give you much more timely feedback. And that gives us, with this data, we're able to really hone in on areas that your hospital could be putting some more attention to or could be improving. What areas are your real big strengths that you guys should keep up as well? And so I think data can be a really helpful way to utilize that and to recognize those areas of improvement, but also where you guys are excelling. Same for the targeted QI. Again, we're looking at not just the NTSV rates, but we're looking at who's meeting criteria and really providing that timely feedback so that there is time to make those process changes or procedural changes within your unit and bring more awareness to what are the criteria and are we actually doing everything that we can to make sure that each patient that goes in for an NTSV C-section is in fact meeting those criteria when they qualify for those labor dystocias. Same thing. We do also submit data. Sorry, Sydney, if you could just go back. For the AIM data center, we also report some of the data that you all submit to us in terms of the race ethnicity breakdown, the payer breakdown of the data that is that we get through CDPHE. This helps us, again, show the incredible work that you all are doing. This is statewide, in which then they are able to show on a much grander scale, on a nationwide scale, how Colorado is doing with these different programs, with these different AIM bundles. Lastly, for benchmarking, we've done a lot of work recently in trying to make sure that we are comparing hospitals in a way that is similar in terms of volume, size, to make sure that you guys have a really good idea of who are we being compared to. Obviously, I'm not going to try and compare a hospital with a birth volume of 150 to a hospital that has 3,000 births every year. How can you utilize those comparisons to really see where you can be improving, but also, again, because this is a learning collaborative, get in touch with those other hospitals that are doing really well, that you're having that same benchmark. What are they doing that you could then adapt for your unit? What might you be able to share between those other hospitals as well? I want to leave you all with one other question, which is, what data do you wish you had that you don't currently? This could be on the dashboards, this could just be internally. What more would you guys want to be seeing, or what is really of interest to you and your unit that you aren't currently getting? And let's see if we can get that data for you. As always, before I hand it back, as always, if you have questions, comments, concerns, I am always by my email. Feel free to email me at any time. And I look forward to seeing you all.
Thanks, Gretchen. Guys, I just need to brag on Gretchen a little bit. I know this, you would not know this, but she's not a clinician. She's not a doctor, midwife, or nurse. But look at how she can navigate this data as if she's in the delivery rooms and knows exactly what it all means. So Gretchen, up this to you.
I've had great teachers. I feel like I could deliver a baby at this point.
I think you could.
I'm not going to do that.
Yeah, and you could avoid an NTSBC section at that.
True.
Guys, feel free to keep using the chat with what data that you would love to see, but maybe don't currently have access to. We're going to move on and we're going to do a really rapid round breakout session. So if you don't have your cameras on, now's the time to turn them on for us. I'm going to give you guys 5 minutes to very quickly discuss, and someone needs to be able to report out in the chat when we come back, and so someone take some notes. I'm really curious about what you guys consider makes a great birth, or what makes a great labor and delivery unit. I want your opinions on that, and then I want to know, how could that actually be measured? Okay. Sydney's going to break you up into breakouts, have some great conversations, come back with some things to share in the chat for us. Welcome back, everybody. I'm sorry that probably felt fast and furious, and I always hate when it cuts you off mid-sentence when you're trying to share probably your best idea. At least one person from your group, please report out to us in the chat. We have some more content we want to cover, and so I'm going to keep on moving, but I am super interested to hear about what you guys consider a great birth, a great labor unit, and or how we already do or could be measuring it. We'll be taking notes, so share it out while we keep on moving. All right, guys, let's go to the next slide. Laurel, stop it. Okay, so we have had a lot of questions about the data that we share with you from the Department of Public Health, where it comes from, how they get it, how it compares to the data that may or may not be in your EHR. And so I just wanted to do a quick workflow for you guys about how that works. First, your hospital fills out a birth certificate. So a baby is born, and then someone on your unit is responsible for filling out the birth certificate. I polled a couple of our hospitals to see who is that, how does that work? A couple of the responses are here. The consensus that I got is that it's a little bit different at every hospital. Some people have birth certificate registrars. For some people, it's a nurse who's identified, or it's a nurse manager who's doing it. Other, it's a collaborative effort with who works on the birth certificates. One of the things that was highlighted, though, is that there's not always a process for quality checks. right? For looking back at the birth certificates and someone sort of double checking, is the information correct? And was it correctly moved from the EHR into the birth certificate? And so for that reason, you might actually see differences in what the state is reporting for your data and what your actual EHR says. So if you're getting data back from us and you're thinking, ooh, that's not the NTSVC section that we had documented last month, or that seems really odd for our indications for NTSVC sections, let's go ahead and back and let's look at who is doing your birth certificates and what is being submitted to the Department of Public Health. But I want you to know that the Department of Public Health, that is like state-based record data, right? Like you want to be reflecting that as accurately as you can for what's actually happening at your birthing facility. So your hospital fills out a birth certificate, they submit it to the state, the Department of Public Health, and then the Department of Public Health on a monthly basis submits it back to us. So they'll give us a report. We have a data use agreement with them, and then we've requested specific elements on birth certificates that they send to us that directly relate to quality improvement for this program. I'm going to quickly show you a birth certificate to show you sort of the level of detail that is on a birth certificate is always shocking to me. The amount of sort of data points that we could gather from that, very surprising. So we get that data back and then we put it on your data dashboard. That's how that process works. We also get what's called balancing measures, right? And so we want to be sure that if we are lowering your NTSVC section rate, we're not making other outcomes worse, right? You're not then increasing your NICU admission. You're not increasing your maternal hemorrhage rate. You're not increasing your rates of sepsis, right? We want to be doing this safely so all around outcomes are improved. So those balancing measures are something that we also get from the birth certificates. So you'll see a couple of those on here. This is, again, I'm not going to like walk you through the whole birth certificate. If you were like me, I was surprised at how detailed these are and the amount of information that we can get from the birthing parent and from the infant. So here's where we get the data for your NTSVC section rate and your indication for NTSVC section. And we can cross-check that with what's happening in your hospital EHR. You can go ahead and go to the next page. Perfect. This is where we get some of the balancing measures that we look for. We also can look at was an assisted vaginal delivery attempted, right? And so again, some of the things for maternal morbidity and number 47, again, are where we can get your balancing measures. We don't get every single element off this birth certificate, but if you are curious to know what data we have from your birth certificates, we are always happy to share it back to you. The balancing measures are reported back to us only if the N value is more than 3. So if you have a very small birthing hospital volume, I might not have great balancing measure data for you because it's not actually reported back out by the state because your volumes are so low. But again, if you're curious to know, Amber, what is the data that you have on my hospital for balancing measures? Happy to report it back to you confidentially. Go ahead and go to the next slide. This is the final one that I'll share with you. And again, this is where we get a lot of the complications that happen for the newborn. And this is where we can get information like APGAR score is a balancing measure that we can report back to you. So your average APGAR scores, if they're increasing, decreasing, have stayed the same, even though you've decreased your NTSVC section rates. So I thought this would be interesting to you guys. It's always interesting to me. If you have questions about birth certificate data and or what we have, we can report back to you, please contact us. Sometimes it's a little bit overwhelming, the amount of information that we get from the Department of Public Health. And also it's not always useful for our program, right? I shared that first quote that like what we measure gets managed, whether it's useful to us or not. And so we want to be mindful of the data that we're giving back to you and making sure that it's actually helping you with your NTSVC section reduction efforts. So you can go ahead and go to the next slide. We're going to briefly show you that for many of you, you participated in our labor culture survey that we did at the very beginning of the year when you guys first enrolled in the program. We did a QR code that you guys rolled out to your entire unit. Anyone on your unit could have responded to this. So providers, nurses, midwives, front desk, scrub techs, we had doulas respond to it. And so it's pretty varied. Those of you who had more than 10 people in your facility respond to this survey got your data back. So if you're curious as to like why you didn't get your data back, if it was less than 10 people that responded, it was no longer really anonymous. So we were cautious about sending those back to you guys and wanted to be mindful of saying that this is an anonymous survey. Some of the things that we pulled off of this survey is that you guys want education. Many of you guys are already doing education for your nurses. Many of our hospitals are doing spending babies this coming year, but the request was pretty much a resounding, our nurses want more education on labor support and how they can be most useful in the labor room for hands-on support. We listened. We're partnering with a couple of our hospitals here to develop a labor support training. So the dates, the times are coming soon. It's going to be from June, July, August, and September. We're going to host 4 different sessions. They will be free for your employees. Anyone can attend, physician, midwife, nurse, doula, anyone from your facility is welcome to attend these. There will be a slight limited number of seats, right? Just because we want it to be a high quality training where you can get hands-on support from your trainers. But please be looking for that probably in the next week or so. We'll be sharing out those dates and giving you guys more information on that. It won't be spending babies. It won't be bundle birth, but it will be the similar principles to these types of classes with hands-on support. There will also be a respectful care and equity component, which I think is really important and not all labor workshops cover. So we're super looking forward to that. Go ahead and go to the next slide. I know I'm talking fast, guys. I want to use our time wisely here, but a couple of things I wanted to touch on is that we keep asking you guys about these structure measures. You fill out a quarterly survey for us and SurveyMonkey to tell us how are some of those foundational practices and policies and sort of cultural based things on your unit going, and what are room for improvement, and what are the tools maybe that you guys need to be able to do them better. So this month we're actually asking you guys about how it is you're communicating with patients who had a traumatic or unexpected cesarean birth. We know that a traumatic birth is whatever the patient considers a traumatic birth, not necessarily what the healthcare provider considers a traumatic birth, and a process by which you can debrief with those patients and offer them resources for their postpartum care, a very important piece. So we can go to the next slide. What we are doing on our team, actually we can go to the next slide, sorry, is we're gathering resources, right? We're looking around at the literature and saying, what are the best tools that are out there for trauma-informed follow-up care for patients who had an unexpected or traumatic C-section? No surprises here. There's not one best practice resources out there for this. And so we're drawing from other countries. Australia has lots of great work for this. England has lots of great work for this. And we're looking locally as well. Our goal is to be able to give you guys back a resource for this. So if you don't already have a resource for trauma-informed care for an unexpected C-section, we're going to at least give you a foundational starting point for that. One of the things that we're doing this month is we're going to survey the providers at your hospital with what they are offering patients. What we heard from our nurses is that they don't always know the conversations that are happening between the provider and the patient when they're doing their postpartum rounds, or even when they see them outpatient for postpartum follow-up and they're discussing sort of trauma-informed resources that are available to support patients. And so we developed a very brief survey that we're going to share out with you guys this week to poll your providers to say what's happening in the room with the patients, what are the resources that you guys are using, and we can also draw from those resources to make sure that they're local and relevant to Colorado. So again, this is just an update for you all that we're making some headway on making sure that you guys have some resources and that they're high quality and relevant to your sites. Go ahead and go to the next slide. I want to end by sharing this. Some of you probably saw this late last year. One is that the CDC put out a report in September of 2023, and this outlined birthing people reporting mistreatment during pregnancy and delivery. As a midwife, this is pretty distressing to me to see these survey results. It was pretty shocking that 1 in 5 birthing people report mistreatment during labor and or birth. And that number increases to 1 in 3 for Black, Hispanic, and multiracial birthing people. A shock to me last September. Just this month, JAMA sort of took it one step further, and they also published on disparities and mistreatment during childbirth. And there's a couple things I wanted to pull out for you guys that are really relevant to our programming specifically. So if we can go ahead and go to the next slide. I have not really seen this in literature. I think we often talk about how substance use disorder can have stigma and mistreatment associated with it, or intimate partner violence, some other social determinants of health. But this JAMA article highlighted that having an unplanned cesarean birth increases a patient's risk of being mistreated during labor and birth. And that it's often involved with a lack of communication regarding the indication for the procedure. So when you guys keep, or maybe confused by like, oh, we're talking about, do you have a process for debriefing with the patient? Do you have patient inclusive labor huddles that you guys use routinely? Do you have trauma informed resources for patients who had an unexpected or unplanned cesarean birth? This is why we're really focusing on that. We had a couple of the sites say, gosh, well, they've already had their NTSV C-section. Why are we focusing on that? It's not just sort of preventing unnecessary cesarean births. It's making sure that the patients who really did need a cesarean birth have the highest quality possible care and follow-up for their birth. And so, again, I don't know if you guys have thoughts and feelings about this. I had some. I couldn't not share it with you all. If you're interested in the article, we can share it out. It's available open access online. And so I encourage you to read it. And yeah, we will share it out. We will go ahead and move on. It's hard to move on from that because I think it's such a, I don't know, it was a very surprising article to me. Next month, what we're going to talk about is how to pilot changes. What are the changes ideas that you guys are doing on your unit? We're going to come back to some of the foundational work that you guys did at our in-person forum. If you guys remember the Jamboards that we used and the breakout sessions that we used, we're going to bring those back in and say, what were the ideas you were thinking of in January? Have you done any of them? And what are opportunities to continue doing them moving forward? We're also bringing the QI expert from California. Everybody loves the California PQC. We're going to bring them in to share what has California done that has really impacted their C-section rates. Really excited to hear from them. And then, of course, we have a couple hospitals that have signed up to share out with us. So thank you for those who have already signed up. I think maybe there's just one more slide. Possibly. Perfect. These are your to-dos before you leave. Schedule your coaching session for this quarter if you haven't already. Sydney would love to get you on our calendars so that we can touch base with how you're doing in quarter two. If you haven't already, go ahead and submit your data. Gretchen was applauding all of you for submitting your data on time, like very high rates of data submission. We're super proud of that. Keep it up. If you haven't submitted data yet, it's never too late, right? Go ahead and get into REDCap and give us whatever data you have so we can get it back to you. And then share that data back to your team. If you can take anything from today's session back to your hospital team, do that. Is it the article that we shared? Is it your run chart? Is it your leading indication for NTSV C-sections that Gretchen showed you how to access? Think of one thing that you could bring back to your frontline team and go ahead and do that. We want to keep them in the loop. We talked about managing resistance to change. The best way to manage resistance is to communicate. Communicate with them what you're doing, how you're doing it, and what the wins are that you're seeing. And then finally, mark your calendars. May 22nd, almost the end of the school year, is our next session, 12 to 1. As always, our sessions are always recorded. Sydney sends out an amazing follow-up email. So if you have questions, concerns, anything from us, from Gretchen, our data analyst, we are always here. Our doors are always open to you. Whew, that was fast and furious. We have 1 minute left. If anyone has questions, feel free to speak up or use the chat. Otherwise, guys, it is always lovely to spend your lunch hour with you on these Wednesdays.